It's my pleasure to introduce today's speaker, Dr. Barbara Howard, President of Total Child Health. Dr. Barbara Howard is Assistant Professor of Pediatrics at the Johns Hopkins University School of Medicine and co-creator of CHADIS. She's the President of Total Child Health, distributor of CHADIS, a web-based system for delivering pre-visit screening and diagnostic questionnaires linked to decision support and resources. After studying animal behavior at Cornell University, she received her MD from Johns Hopkins and completed pediatric residency training at Children's Hospital Medical Center in Boston. She had fellowship training at Harvard in child development with Dr. T. Barry Brazelton and has been faculty for residency training in developmental behavioral pediatrics at Johns Hopkins, Sinai Hospital, University of Massachusetts Medical Center, and Duke before returning to Baltimore. She co-founded the Center for Promotion of Child Development through Primary Care in 1996 with its clinical laboratory for research and applications to primary care. Dr. Howard is past president of the International Society for Developmental and Behavioral Pediatrics. She has served the American Academy of Pediatrics on the local and national level, including on the Task Force on Mental Health, and as a regular speaker at meetings around the country. Dr. Howard was the 2019 recipient of the American Academy of Pediatrics C. Anderson Aldrich Award for contributions in child development. Dr. Howard, thank you for joining us today. I'm going to stop sharing my screen, let you share yours, and you can take it away.
Thank you so much, Alex. It's a real pleasure. Speaking with your group today. I know that I've met a number of the people who may be listening in on this call, and I hope to meet more of you as time goes on. I'm very happy to be talking today about social determinants of health because while it's an important topic, it's also a thorn in the side for a lot of pediatricians. So we'll talk about both parts of that. My disclosure, Alex has already helped me with, and that is that I'm one of the creators of CHADIS, and I will be talking about that, but I will not be talking about any unapproved or investigational use of commercial products. So fortunately, you didn't miss much except my disclosure, which you probably heard. So the American Academy of Pediatrics, since 2013, and really actually before that, has formally suggested that pediatricians need to be paying attention to social determinants of health because these are mediators of known adverse outcomes for children. And some of the factors that they mentioned in the Poverty and Child Health Statement back in 2013 include parental depression, smoking, addiction, intimate partner violence, food insecurity, and harsh punishment. But I would definitely want to add to that other social determinants that are in the news today and have been factors for many, many decades, and that includes racism, poverty, and homelessness. There are many more, but those are the ones the Academy has talked about. Now, this topic, it turns out, is much more timely than when I was first invited to speak about it, actually, because of the COVID-19 virus. So it turns out that even viruses are not equal opportunity infectors. So it turns out that low-income people, often people of color, are more likely to work on the front lines where they're exposed, to live in crowded homes or even homeless, to have less access to healthcare and testing, and no sick leave or personal leave to take time off of work. They're more likely to ride public transportation where they have crowding and exposure, and to be employed in jobs that don't allow for telework. Often their employers are less concerned about their personal safety or providing things like personal protective equipment. And if they are able to stay home and quarantine, they're less likely to have access to the internet for work and for schooling their children or themselves and to get information. Low-income populations are also more likely to have obesity and chronic conditions that increase the risk of a severe case of COVID. So this is a very timely topic that I wanted to point out those factors. So when you think about social determinants of health, two major categories. One is what happened to you a long time ago, and those often fall in the categories of ACEs and trauma, and also the factors that a person and a family are dealing with right now. And that includes stressors, risk factors, and the fact that there may be fewer protective factors. So I'm going to break those out separately. So let's talk about adverse childhood experiences for a moment first. So it turns out that the things that happened to a person before they were 18 years old, because that's how it was studied, are considered chronic stressors and that the outcome in terms of health is a graded dose-dependent outcome that's related to the number of those risk factors that a person experienced. And you may have heard this sort of thing before. How does that actually work? So how does what happens to you when you're 3 turn into a long-term health consequence for you as a grown-up? Well, part of the reason this happens is that people who have been very stressed are more likely to adopt coping strategies that are actually bad for your health, like smoking, substance use, or early sexual behaviors. They're also more prone to get into violent situations in the future, to have unintended pregnancies, and to have adverse health outcomes such as suicide, depression, obesity, heart disease, and liver disease. Now, if those sound like really diverse health outcomes, they are. And what we're beginning to understand is how inflammation plays a role in that, which I'm going to talk about in just a moment. A very shocking fact is that of the 10 adverse health childhood experiences that were studied in the original project by Dr. Felitti at Kaiser Permanente in California, people who had 6 or more of those experiences had an average life expectancy 20 years shorter than if they had not had those 6. Up to 40% of early deaths in America and around the world are due to early childhood experiences of this kind. So I hope that makes you gulp and think hard about the opportunity as pediatricians to make a difference in those first 18 years. Well, how is that mediated? How do the actual stressors turn into life effects? Well, in animal studies, there are varying nurturing effects that make a difference to the neural functioning and later cognition of the animal. And stress responses and psychopathological behavior comes from epigenetic changes in the DNA, even without affecting DNA sequencing. So it changes the histones, it changes the methylation of the DNA, and this begins even as a fetus. When the mother is experiencing these stressors, the fetus is actually getting changes to the methylation of their own DNA, so that this can actually even be passed along in subsequent generations. Now, some of the things we know about afterbirth include the fact that babies who have been exposed to these stressors are more likely to be born low birth weight, and that early postnatal exposure to maternal stress results in a change in reactivity to stress, so that the child becomes more aroused by stressors that other people might be able to just pass off, and it alters the actual developing neural circuits that control their neuroendocrine responses. That's called the HPA axis. This actually can change the brain architecture, particularly in the areas of the brain that are high in steroid receptors, so that there's more anxiety-related hyperactivation in the amygdala, for example, from stress. These children develop less control as a result of PFC atrophy. There's impaired memory and mood control as a consequence of reduction in the hippocampus. And this affects the regulation of stress physiology, learning new skills, and developing the capacity to make healthy adaptations to future adversity. So the kids are really off to a really bad start when they've had this kind of exposure. So altogether, these stressors have been called toxic stress. But toxic stress by itself doesn't affect everyone the same way. Toxic stress is defined as the excessive or prolonged activation of physiological stress response systems. Listen to the second part of this. In the absence of the buffering protection offered by stable and responsive relationships. So if you're in a stable, responsive relationship and good circumstances, those same stressors that might throw another kid for a loop actually may not be such a serious adverse event. So it does produce biological memories in the brain and the genome. So some examples of stresses like that would be considered toxic stresses are child abuse, child neglect, and parental substance use, maternal depression, and racial discrimination are all produce toxic stress, which are among the adverse childhood experiences. So now I'm going to get more practical. You may actually already know all of the things I just said about the physiology, because there's been much greater attention to this role that we have in preventive health care. So we do preventive health care most notably by giving vaccines and also by giving anticipatory guidance. But another aspect, which is probably more powerful than that, is to be able to help with these adverse childhood experiences as well as current stressors. So next, I'm going to talk about some kinds of tools that you might use to pick up on adverse childhood experiences. So here's some choices. So the first one I'm going to tell you about is the original Adverse Childhood Experiences Survey by Dr. Felitti, which is actually these 10 questions. And as you can see, they cover things like people who are swearing, putting you down, or humiliating you, pushing, grabbing, or slapping you, sexual touching that was inappropriate, lack of a loving relationship in the home, and then more practical stuff like not having enough clothes to eat, being abandoned by your caregivers, seeing your caregivers experience violence, having caregivers who were using drugs or alcohol to excess, having somebody with a mental health disorder in your household, and having someone in your household go to prison. So these are the original 10. You can probably think of a lot more, but these are the ones that were studied. So that's the tool that can be administered to people who are already after age 18. But what about detecting these things in the children that you're taking care of right now? So there's a wonderful organization called the Center for Youth Wellness out of San Francisco that has created tools called the ACE-Q. These tools include the 10 standard ACE items, but talked about from the point of view of a developing child, plus 7 additional environmental stressors that I'll show you, but that we recognize as being harmful. And there are different forms of the tool. There's the parent reporting about the child, there's the parent reporting about a teen, and there's the teen reporting about themselves. And there's 2 ways of looking at the results. One is to actually see what it was they experienced, and the other one is simply to have the score or the total count of stressors that the person is experiencing. So these are basically concurrent for most kids because they're asking about how many things apply since the child was born. So that might be something that happened already in the past, but it might also be happening right now. So you'll see that there's the same ones I just mentioned: divorce, jail, mental health, violence, humiliation, sexual, as you can see, housing, food, and clothing, observing violence, parents using drugs, and being unloved or unsupported. Now being asked about in terms of the parent's perception that the child has experienced this. And then here are the 7 additional environmental topics: foster care, harassment or bullying at school. We've come to recognize how important that is. The loss of a parent through death, deportation or immigration, separations from that, serious medical procedures or life-threatening illnesses turn out to be a very powerful stress, particularly at a young age, under age 4, violence in the neighborhood, and discrimination. So this is a simple question asking about being treated badly because of race, sexual orientation, place of birth, disability, or religion. So the results of this can be displayed simply as a number, or it can be displayed where you actually can see, this is in CHADIS now, you can actually see what the factors were, and then any ACEs above 3 of the 10 is considered to be more than borderline, so a very significant risk, and social factors are just counted up. So that's one form of that tool that you can have access to, and you can also get it for the Center for Youth Wellness. So the problem that comes to my mind immediately is that, yeah, the American Academy of Pediatrics says everyone should be screening for ACEs. But then they say, but they never tell you, then what? What do you do about it? This is something that may have already passed. What can we do to make a difference? So the way we've been thinking about this is that pediatricians have an opportunity to help chart a positive parenting course to help parents understand these factors and to do things that will provide a nurturing environment that buffers in the way that buffering of toxic stress can be effective in reducing the impact of these problems. So what we first decided was that it's probably a good idea not just to ask about the bad things that happened, but also ask about the good things that happened so that you can have a balanced discussion and help the parent connect things that happened in the past to things that happen in the present or the future. And we've created a teleprompter of a suggested language for helping the parent think about, along with you, what they wish to create for their child. And there's even a picture I'll show you in a moment. A good time to do this might be very early in your relationship with the family, because we're talking about things that happened that were bad for the parent that the child hopefully has not yet experienced. So it's really a preventive effort. So this is a list of a comparable kind of 10 things that we know from research are buffering factors. A good relationship with your own mother, with your own father, affection, praise, playfulness, like singing songs, having social support, someone else to help take care of you, playfulness in the family, compassion and recognition of emotion, and reading stories. The other nice thing about this list that we created, again, from the literature and adding a few things of our own, is that it then gives you a list of things that you could actually recommend that the parent work on with the child as part of that buffering relationship that we're aiming for. And then we created and tested in focus groups a picture that helps with the conversation. So here's the picture, and this picture has been pre-populated by the bad things from the ACEs and the good things from the positive childhood experiences, with a road that diverges in the woods here between a stormy future and a sunny future. So one of the first things to do if you're going to collect information about a parent's own adverse and positive childhood experiences is to ask, are any of these still bothering you? Or what kind of impact are these having on your life? Because if the parent says, you know, I dealt with that when I was younger, and it really doesn't bother me anymore, that may be a short conversation. But if they start to tear up and say, I've never gotten over the fact that I was sexually abused, and now I can't seem to have a stable relationship with men, means that this child may not have the opportunity to have a caregiving father, because the parent has never overcome that kind of a risk factor. So this graphic is an opportunity for what might be called shared decision-making, and it's accompanied by hints for the clinician and resources that can appear automatically inside of CHADIS in the care portal, as well as text reminders and emails to remind parents about the things that they said they wanted to do better for their kid. So it could remind them about, hey, you said you were going to read, that you enjoyed as a kid having stories read to you. We're reminding you that you wanted to do that with your kid. How's it coming along? And maybe even resources like access to reach out and read materials. So that's an example of how ACEs can be built on. The other thing about ACEs to keep in mind, as well as positive childhood experiences, is that it doesn't just come up once. So parenting is a long process, as you well know, probably a lot of you from personal experience, that the stressor may come up when the child reaches the same age that that parent was, or when the circumstances change and there's violence in the neighborhood, such as the violence that happened before. It will reawaken those stressors. And so for you as a clinician in a continuing relationship with the family to be aware of that and be able to help the parent with it when it comes up again is very valuable. And what we found, our experiences, and that's my experience as a clinician as well, is by reminding them that you know about this and that you're prepared to help them through it is a huge intervention, that parents are able to handle stuff once they can make it cognitive, and it's no longer jerking them around as simply an emotion. So that's what I was going to say about ACEs and what we're trying to do to help with it. Now I want to talk about current social determinants of health. That means bad stuff that's happening right now. There are a lot of questionnaires available for this right now. So here are some that I'd like to point out to you. So first of all, just the ACE and the ACE PCE. In California, there's a tool that's a lot like that ACE-Q that I just showed you, and that's called the PEARLS. There's lists of potential stressors. Many of you may know about the PROPARE, protocol for responding to and assessing patient assets, risks, and experiences. And there's actually a Prepare Lite tool, which is much shorter. There's a protective factors survey. There's something called the SCC psychosocial screen, which I like quite a lot. There's a tool that upon which we've been working, and we've been collaborating with the original author, Howard Dubowitz, called the Safe Environment for Every Kid, or SEEK. The Hunger Vital Sign is about food insecurity. NC Care 360 has a short screener. There are separate partner violence screens, including the HITS and the HITS-P. Anxiety is another adult screen that's valuable and is now recommended for all women's health. I don't know what they did to leave out the men, but it's just recently to come out as a recommendation for women. And of course, depression tools include not only the Edinburgh, but a 2', the PHQ-2, which is part of just the 2'. It's also included in the SEEK and the Family Assessment of Safety and Stress, which is our tool, and substance use screeners. So if that sounds like a lot to choose from, well, you know, it's like a lot of tools. Take a look, see what you like, pick out one for your group, and start using it so you become familiar with what kinds of results it gives you. Here is a table of the kinds of results we've been getting in terms of percentages of people affected in national use of CHADIS, where all of these tools may be used by different groups. And you can see that even though the rates are low, they're really important. There's another thing I'll tell you about in a moment about what happens to these risk factors over time. Now, the other part of looking for traumatic events is to think about using a trauma screener. And here are a number of trauma screeners. This is the parent report, a child report on the Connecticut trauma screener. It doesn't have to be used in Connecticut. That's just where it came from. CHADIS has a life events scale, potential stressors, and there's some formal diagnostic tools that actually are looking for effects of trauma on the child. If you want to get into more depth, these are interview tools for the clinician for PTSD and for reactive attachment disorder or disinhibited social engagement disorder, which are the terms for the young child forms of post-traumatic stress. So, okay, now we've found these current stressors. Then what are we going to do? Well, I think that it's useful to think about trauma-informed care as being part of everything that we should be doing every day because trauma is so common. The first thing about trauma-informed care is that your entire team needs to be educated and sensitive to the fact that the way this family is working, operating, behaving during care or at home may be due to trauma they've experienced. So rather than thinking about them in sort of a negative, stereotyped way, to be thinking about them as somebody who may have been inclined towards this kind of behavior because of stuff they experienced. And so one of the, I think, helpful clues about trauma-informed care is to not only think about, but perhaps instead of asking, what's wrong with you? Now, hopefully nobody would actually say that, to be more inclined to think of it as what happened to you. These are so common as causes of adverse behaviors and adverse parenting that thinking about what happened to you is a very valuable question. Of course, you want to make sure that they're safe right now because some of these things may be going on right now, and to provide non-judgmental support and listening. That is more powerful than you might know. It's very common that people have no one else that they dare tell about the trauma they're experiencing, intimate partner violence being a particular example of that. And even using harsh punishment with their children, the parents themselves don't really want to do that to their children. They don't know why they're reacting in such a way, but they may be reacting that way because that's what happened to them. Then make sure you ask, if you uncover a trauma, how much is this still bothering you now? And be ready to provide mental health referrals for those that are mental risk factors now, okay? Now, if it's a social risk factor, like I don't have any food, you don't have to send them to a mental health referral for that. You need to help give them other kinds of community resources, of course. The other thing to keep in mind is the people who are experiencing a lot of struggle with social determinants of health, yes, we want to give them a referral, but actually the circumstances of their lives right now make it often difficult to just take a phone number and carry out the following through on a referral. They may not have transportation. They don't have time. Their boss won't let them off of work. Their husband is suspicious about where they're going. They've got too many children to be able to drag them with them all the time. There are all kinds of things that can get in the way of a referral. So it's very important to have a system for tracking and follow-up when you feel that a person is suffering significantly from this kind of event in their life. So it's really important to have a list of referral resources for these things. And there have been a number of studies now that show that simply handing a patient a piece of paper with the resources that are relevant to the problem they're going through right now can be helpful. Okay, it's good if there's a choice of things. Now, maybe you have a social worker you can refer to who can help with that. Hopefully you have a co-located social worker. But there's other programs that are good to know about and to consider incorporated into your practice. One of them you may have heard of is called Health Leads. So Health Leads has typically been a volunteer activity for medical students or undergraduates to actually be in the emergency room, available to doctors to send the patient out to this kiosk in the emergency room where the health lead person is sitting, and that person will talk about the problems and help give them access to the resources, like give them the listings of resources. You probably don't have that in your office, right? But you can get an application called Aunt Bertha that also has a variety of national resources that have been researched by the Aunt Bertha team. United Way has a list like that too. Many states, I think it's 23 now, have Help Me Grow telephone service where you can actually call up Help Me Grow or have the patient call up Help Me Grow, explain their problem, and they will help connect to resources. In North Carolina, there's a whole statewide effort called NC Care 360, which is specifically designed to pick up on social determinants and connect people to services. The backbone of that program is a national vendor called Unite Us that also has resources. This was started by some veterans, so they have a lot of resources for adults as well as things that are more appropriate for children. And of course, you can keep your own list. Now, one of the things about keeping your own list is that if you're more familiar with the resource, you may have more open communication with them, particularly therapists, know what kind of service they provide, know more about their waiting list or what kinds of particular problems they're good at, and be able to refer with confidence for the patient. So keeping your own list is always a good idea. Now, in CHADIS, we keep a list for you for your local resources to make it easier to refer. And I'm going to demonstrate some of that in just a couple minutes. So I've said just handing people a phone number is not good enough. And in many cases, that's really true, not just because of barriers like transportation, but actually other kinds of barriers that provide ambivalence, where the family actually is not sure that it's okay. They're not really ready to accept help for this problem, even if help is available. Now, I'd like to think that that was the most common thing. I think lack of resources is probably more common, but there will be situations that are really dangerous for the child and the family where the parent is ambivalent about it. So the best evidence-based way of helping move somebody towards making a behavior change, in this case, the behavior change is getting help, for example, is to talk to them in a way that you help them explore and resolve their own mixed feelings about making that behavior change. So the focus is to be empathic with the person, non-judgmental and supportive, and help them individually express their own reasons for why they would want to change so that they take responsibility for their own behavior in making that change. And the evidence for this being an effective technique is in positive health behavior changes regarding substance use, oral health, diet and exercise, and weight loss, for example. Motivational interviewing has been shown to be helpful in all of those situations. So you may or may not have had any kind of training in this area. I strongly recommend it if you can get it, because think about all the things that you have to do as a physician, actually motivating people to take your advice applies to lots of problems. You know, it doesn't just apply to the parent's own health problems. It applies to all kinds of things, like keeping the evaluation for autism appointment because they're fearful of it. They may have to have some motivational interviewing just to be able to take that step of going ahead to find out if the child has autism or not. That's sort of one of my pet peeves, which I may have talked to you about before. So what are some of the techniques that go into motivational interviewing? Well, first of all, asking open-ended questions, asking permission to discuss this stressful area, using reflective and empathic listening, sharing the agenda with them for what you're going to talk about, eliciting the reasons to change and the reasons not to change, so the pros and cons for them, their own personal pros and cons, and provide information using the elicit, provide, elicit technique. So if you haven't heard of this before, basically ask a question, how are things going with your partner? Provide information. I know partners getting rough on you is very, very scary and can cause you to be frozen so that you really can't see that there's any help in sight. And then elicit again. Have you been able to take steps towards this? How are you feeling about your ability to do something about it at this point? So that's elicit, provide, elicit. That's actually good strategy for lots of kinds of communication. Try it at home. You might like it. Then looking for readiness for change. So that means inquiring about the importance of this problem to them and their own confidence in being able to make a change and to address that problem. And of course, providing a summary. And what's missing from this list is give them something on paper, at least, okay? Or send it something so they have something in writing to lean on. So as you were listening to this, you were probably thinking about Prochasta's stage of change model, where people go from pre-contemplation, I haven't even thought that I could do something about this, to contemplation, yeah, this is some kind of a problem, to preparation, I'm not sure what I'm going to do about it, but I'd like to do something, to action, actually doing something, and then maintaining the change. And then what's common for human beings is relapse, and you have to go through the whole thing again. But of course, what we're aiming for is that they'll make a change, maintain it, and have a stable lifestyle, whatever the problem was they were trying to address. Okay, so sounds great, right? Have you got an hour for your session? Probably not. So there are a number of barriers to using motivational interviewing in primary care. One of them is some patients will say, hey, doc, it's none of your business. I'm here for my kids' shots, right? So their expectations that these things are appropriate topics for the visit require some finesse and a relationship, and also basically repeatedly having the well-being of the family be part of your visit. So when it is time to talk about making a change for something that would affect their child but has more to do with the whole home environment, makes it easier when it's necessary to actually push along to have them do something about it. Training, as I mentioned, is very helpful. And then, oh my gosh, time, right? And I guess I should put time and reimbursement down there too. So how much time do you have to do it? So as a clinician myself, I've been thinking about this a lot and what can actually be done in primary care. And that's what we have built into CHADIS. Some of this you can adapt to do in your own way with paper screens and paper resources, but we have something to offer you that I hope you'll be interested in it. So first of all, using validated social determinants of health, that's what SDoH stands for here, in the course of regular care visits makes it more of an expectation of care. And boy, when people start doing this, one of the things they notice is, wow, I never would have guessed that these people would have had trouble with food insecurity, or I never would have guessed that their marriage was on the rocks. They come in here, I can't tell. So people are much more able to express their concerns and to basically admit to things that are happening in their lives when they do it on a paper tool and even more so if they do it on a computer tool. That's just the data. It's not our data, that comes from other research. So being able to screen regularly in the course of regular care visits improves your chances of finding these things out. Patients are more reliable when they do that. And at the end, you have a more standard format of structured data that allows for things like assigning resources, right? Making resources available to them. This sort of standard way of collecting data also provides a needs assessment. Per patient, you find out what your patient needs. Per system, you find out what your health system or your clinically integrated network, what the patients in your system need. And of course, when we get to a larger data size of an endeavor like North Carolina, you're trying to find out, what does your state need? Like, this is basically finding out what resources are necessary based on what kinds of problems there are that families are having and their prevalence. Then we have a way of providing the clinician patient-specific guidance with motivational interviewing cues to help the patient be encouraged to get help, and local agency listings that are sent automatically to their CHADIS care portal. With one click, a referral, including the option of an online consent form, can be sent, and you can follow up on the needs meeting met by having a scheduled patient reminder that goes as a text message or email to ask how those stressors are going and how whether they've been able to access help. Now, this kind of system of care is really basic to a patient-centered medical home, but it's also becoming useful for value-based payment systems, which we're all moving towards. They promised us that it was going to happen in 2019, but it's still coming down the highway at us that we'll be paid more by value-based payments for the process of care. Also, when you are screening in this way, you have the data you need for negotiating rates with your payers, as well as for population health data. So let me show you around a little bit how this works in CHADIS. So first of all, we call CHADIS a clinical process support system. And actually this week, we've been thinking of changing the name to a clinical process measurement and support system, because measuring the process that you use is part of what will allow you to get that kind of value-based payment, because that's really a process payment, right? So we call it this as a system because of the fact that questionnaires are done online before the visit, either at home or in the waiting room. Nowadays with telemedicine, it's more at home than anything else. And then you, the clinician, at the moment of care, get decision support, scored results, graphics, a special way of getting documentation done, and the ability to do referral and tracking, even for the adults. So one of the problems with being a pediatrician is that the child has a record in your electronic medical record, but the parent does not have a record. So how do you make a referral for a parent and track whether they went or not? That's where having an outside system, software as a service like CHADIS, can help you out for that kind of referral and keeping track of it as well. Then after the visit, patients get their own care portal. They can be reminded to do monitoring outcomes. They can be given automatically resources into their portal. They can also look in the portal for resources themselves. And you, the clinician, can get education on these topics, even getting MOC4 credit, as well as automatically getting a result for your chart. So here's how it works. The parent is doing questionnaires from home, a teenager under a separate login. Both of the results go to the clinician, who can share data with schools, for example, therapists or other agencies, put data into that care portal, earn maintenance of certification credit. And by the way, this is billable to insurance, not just insurance extra higher rates because you've negotiated a better rate because of the risk factors in your population, but actually screening tools themselves are billable to insurance for these things. CHADIS includes questionnaires for all ages of child and even for adults, including teen health self-report, teacher tools, anonymous quality surveys, patient satisfaction surveys, which may be something you do in your practice, as well as things for general health care. We've got a wonderful asthma module, we have obesity and nutrition tools, and we have everything needed for EPSDT and Bright Futures. This is part of our list of family tools, and as I said, adult tools as well. Patients can do it on any kind of internet-connected device, and they can choose their language. So if Spanish is their more comfortable language, they can do the tools in Spanish. The results come back to you in English, but CHADIS works on any kind of internet device. So now let me tell you about the adaptation of the SEEK that we've made, which we call the FAS Plus. So the FAS Plus stands for Family Assessment of Safety and Stress. And the plus is because of the way it helps start a motivational interview. So the FAS Plus covers, in 14 items, it covers these most common factors that cause a bad child outcome. In particular, it was originally developed to help prevent child maltreatment. So food insecurity, parental depression, parental substance use, excessive life stress, harsh punishment, and intimate partner violence. And in 2 positive randomized trials in primary care, the effectiveness of the SEEK was found for reducing some of the child maltreatment indicators. And as a result of this, this tool has been given top rating for strength of evidence in preventing child abuse from the California Evidence-Based Clearinghouse. So that's about as high as you can go in terms of evidence-based tools. So how does this work? Well, within CHADIS, we create a patient-specific template that is pre-populated with the results from the questionnaire that the parent filled out, gives links to graphics, the teleprompter for the motivational interview, creates a summary report, automatically sends educational materials and resources to the parent, and it can also be printed out. So here's an example of how the questionnaire works. So this is one question that's a very valuable question to ask. In the last year, have you been afraid of your partner? So that's an intimate partner violence screen. So if the patient says no, okay, you go on to the next question. If they say yes, however, it then asks them about the severity. So what kinds of things are happening? Fighting, yelling, threatening to hurt me. It asks about current risk. How much contact do you have? Every day or most days? Are you getting help for dealing with this problem with your partner? So remember, only people who said yes to the first question would even be asked these other questions. If they say no, then they're asked, do you want help? If they say yes, well, you're basically partway there with your motivational interview. They're already asking for help. But if they say no, I don't want help, the computer asks them, what's getting in the way? What makes it hard to get help or to want help with this problem? So this is elucidating the barriers. Well, my partner might get mad and make things worse. And actually, that's actually one of the most common reasons for not getting help for intimate partner violence. Okay, that was from the parent point of view. Now you, the clinician, log in and you see this information. You see the results of the questionnaires, of course, but you can also see an outline for a motivational style interview. Now, I don't want to say it's a full motivational interview, but it's in that same format, reflecting on the reasons not to change. So first of all, you acknowledge that they have this problem. I see you've been concerned about your partner getting mad about if you go and get help for this. Empathize. You're right. Doing something about the problem has risks. And then talk about the reasons to change. And it sounds like while you're in a difficult situation, doing nothing has risks too. It's important because issues like these are known to be unpredictable and potentially dangerous. And it looks like it's already affecting your sleep and your friends. Now, how do we know that? Well, actually, the questionnaire asked about effects. I didn't show you those questions, but they were in there. And it's put into this conversation here. And then assessing readiness. Would you be open to talk to somebody who's very experienced at dealing confidentially with difficult partner situations? It's also important to have an escape plan for your safety just in case. So all of that, we don't expect you to read that during the visit, but if you can look at your questionnaire results before you go into the room, you're going to be ready to think about this, and you can quickly glance at this, and most people will look at it a few times to get the hang of it, and that puts you in a better position to have this difficult conversation. Another aid to having this conversation is something that psychologists use all the time, and that is a kind of a pros and cons list. Well, maybe you don't have time to make a pros and cons list. Well, actually, the computer does have time. So in this case, it collected the reasons not to act. I love my partner might get mad, and the reasons to act that come from the way it's impacting my sleep, my friends, my children, taking care of my children. So that can actually be shown to the patient for some shared decision making to decide about accepting some help that you might be able to provide. And then the computer automatically creates handouts, including safety numbers here and links to local resources for partner violence by your zip code. These can also be printed and personalized if the patient thinks that or you don't think that they will look in their care portal, or they don't want to have anything in the computer because they're afraid the partner will find out, even though the care portal is actually private. Now, these resources also show up here in the care portal. So this is just the header. If you click on that, it would actually give those same resources that I showed you in the last slide. And personalized information can also pop up. So here's a person who reported depression symptoms, and this handout in the care portal is specific to them, includes links to more strategies and to local resources for maternal depression. Here's a handout, for example. Now, I mentioned to you that we have within CHADIS referral and care coordination tools. So you need to figure out how you're going to make referrals. I got that. And if your electronic record takes care of everything perfectly, or you have a care coordinator sitting right outside your office door or your visit room door, you're in great shape to be able to do that. But we know that not everybody has access to that. So we've created a consent form inside of CHADIS that gives permission for the agency that you're referring to reach out to the patient, like not wait for them to call, but actually call them, as well as permission to share information. And this information can be sent by email or e-fax with the documentation of that consent. And in the case of a cooperating agency, to be able to actually share information from within CHADIS, and for the agency to send back a status of service update that will appear in CHADIS as well. All of that is automated. So here's an example of the communication, and you can put your own notes in here as well about something specific you want to say about it. And we've set it up so that when the FAS, or Family Assessment of Safety and Stress, is positive, the results are broken out so that you can see which area is abnormal. Well, hopefully you'll never see one like this. Actually, only about 20% of parents will have even one. So this is just an example to show you that automatically a refer link will show up. And when you click that link, it will set up that referral message to go to the specific kind of resource that's appropriate for depression and stress, rather than something for food insecurity. It'll send it to the right kind of place. And of course, you can tailor any of that you want. So here's an example of how it works. This referral form has already been pre-populated with all this information: your office, your name, in this case, the fax number for the Infants and Toddler Program. That's a project we're doing here in Maryland. The name of the patient who's being referred, which might be the kid, or it might be the family member. You can select that, as well as their contact information that came straight out of CHADIS. All of these can be edited if needed. There is a default verbal consent, but you can choose a written consent. When you choose a written consent, the consent form pops up to be signed, and it even says what the problem was in a short form, at least down here at the bottom. This e-fax is sent like this, and if the referring provider is using CHADIS, they can just scan the QR code and it will log them right in. Otherwise, they can just use it on paper. The consent form is similar to this. This is the infants and toddlers consent form, and the parent simply types in their name right here. And then you can see the status of the referral at a later time, right there inside your CHADIS chart. So our goal is the goal I think we all have, and that is we'd all love to be working in a system of care, not just out there on our own, struggling to try to take care of these things. So this is the system of care that we've created and that we're envisioning could become more widespread. The parent completes the screen, you see it, you use motivational interviewing to address it, you make that referral, the agency sees the consent, calls the patient gets the services, the agency sends you back a note through the same system, you can see the results of the referral, and the patient is reminded to do a follow-up questionnaire so that you know what happened, even if the agency doesn't let you know what happened. So that's our vision for this. All of the components are available now. And of course, the other thing this does is it creates a database, not just of the kinds of social determinants that are there, but the kinds of barriers that there are there, and does all of this automatically. Now, I've been talking about this as though you're seeing the patient in person. You may not be seeing the patient in person. Of course, this is an online system. You can do all of this by telehealth as well. Collecting the patient data online allows you to triage who actually has to come in, either to see you or go somewhere else, helping with the documentation, helping with graphics that you can share over the teleconference, and providing those educational handouts and resources and the ability to schedule monitoring and make referrals. All of that can be done wherever you are. It doesn't have to be in your office, and the patient doesn't have to be there with you. We can also provide a registry of anything, because everything is digital. That would include a registry of patients who have identified certain kinds of social stressors, so that your staff doesn't have to track it. You don't have to remember to write it down in a book at the end of the day. All of that can be created automatically. Now, one of the things I'd like to mention is that screening for these things is not a one-time affair, that in our own research of people who use tools, this tool at repeated times, while 76% didn't have any of these stressors ever, many who said no in the beginning said yes later. Some who said yes in the beginning said no, it wasn't a problem anymore later. And of course, many have persistent problems. So they had the problem before and they still have the problem. So this is actually kind of a chronic disease management format that you're familiar with. All of that can be automatically charted for your MOC project or the needs of your clinically integrated network if you're in one of those. Now, these are the billing codes that you need to know about. So FBO, you probably know, stands for the benefit of the patient, okay? So these are risk factors codes for the benefit of the patient. So that EPDS is the maternal depression screening, and the tools like the Seek and the FAST. Okay, nationally, the national average pays $4.51. But the fact is, to provide good care, you probably need to be looking for this. You might as well get paid for doing those screens, and they do add up for you. Okay, well now I think Alex is going to mediate a few questions for me. Is that right?
That is correct. I've got a couple here I'll pass along. First off, just a note that some folks who are just fascinated by the idea of the role of inflammation in some of these processes, and that connection is interesting. So I figured I'd pass that along and make sure everybody here got to hear that. One of the questions we have coming out is, one person was curious how the body of knowledge around positive childhood experiences compares to that around the ACEs. Are these positive childhood experiences a newer area of study? You know, kind of how do those compare as far as how much we know about each one?
Interestingly enough, we know a lot more about positive childhood experiences than the adverse childhood experiences knowledge base, and its long-term impact is much less well known. So that's part of why you're hearing so much about this at CME courses now, is because Dr. Felidi's work really only came out about 10 years ago. So we've known for a long time that, for example, stable, affectionate caregiving with structure and not that's a more equitable kind of structure in the home, and developmentally stimulating parenting with reading to your child, those experiences, we have a long track record of how much they make a difference to child development and subsequent mental health. So we actually have more data on positive than on negative. Actually, I read an article today, and if anybody wants to write to me, bhoward@chadis.com, I'll share this article that shows 3 generations of a program, emotionally stabilizing program done in school. 3 generations of people. It showed the effect of the children of the people who were children in this school environment. Really fantastic to have that kind of data. If I could mention something about inflammation, you might say, you know, we know to give the people should eat a good healthy diet, right, with lots of fruits and vegetables. Is that just so you'll have good bowel movements? Actually, no. That kind of diet is actually partially protective of inflammation. So we're now recognizing inflammatory processes as being important to lots of kinds of health outcomes. And of course, the people who are under a lot of stress are also less likely to be eating those healthy diets. But I just wanted to mention that as a buffer. But the buffering effect of positive parenting was my focus here.
Certainly. That's wonderful. Thank you. Another question or request is, do you have any suggestions for improving compliance rates for any of the screenings that teens complete themselves? This particular person, and we've heard some challenges of getting teens to actually complete these screenings.
Yes, it's hard to get teens to do anything, if anybody who has got a teen of their own knows. So the first thing is to make sure that the teen is reassured that it's private. We've just been doing focus groups. We've actually done focus groups with 78 teenagers, which was actually a blast. And some of it was about filling out questionnaires. And there are a couple of things that the teen said. First of all, I want to know why I'm doing this questionnaire. I want to know that it's private, and I want to know if something good can come out of it for me. And that's really, really important. So because they don't want to waste their time, they'd much rather be playing their video games or talking to their friends or texting their friends than doing your stupid survey if they don't understand what it's for. The second part of it is, in CHADIS, the parent can invite the teen to do their own set of questionnaires, or your office staff at the time that they're making the appointment for somebody who's 13 or up, some people start even at 12, should say to the parent, the American Academy of Pediatrics now recommends that teens have part of their visit be private with the doctor, and they also want teens to submit information themselves. So helping the parent understand what's important and setting them up to do it in advance. The other sneaky thing, not so sneaky, is tell the parent the appointment's at 1, but actually be prepared to put them in the room at 1:30. So plan on having a delay and consider the pre-visit data collection as kind of like a lab test. A lot of people know if you're going to go see an orthopedic surgeon, you got to get your MRI first, right, before you get your visit. Now, I don't agree with that, but in this case, it's very appropriate to have the data collected in advance. It makes for a more comprehensive, evidence-based, and effective visit from the point of view of the patient, much improved visit. So getting that across as a kind of a policy statement is important.
Wonderful. Thank you so much. Those are all of our questions, and we're right at the end here. So we appreciate you being here. Thank you to everybody listening in and watching. Thank you, Dr. Howard, for joining us and presenting.
Can I say one more thing?
Certainly.
I say one more thing? I forgot. We have free case discussion sessions with 2 developmental pediatricians. One of them is me, and a child psychiatrist the 3rd Tuesday of every month at 12:30 Eastern Time. And you can talk about your cases and get free consultation and free CME credit. Just email me, bhoward@chadis.com. I'll put you on the list.
Wonderful. Thank you so much. Thank you again, and we'll see you all next session.
Bye-bye.